Atrial flutter. So atrial flutter is going to be one of those rhythms that I mentioned before that you may want to make assumptions about, because a lot of times once you see that here, it's going to be pretty easy and it's going to stand out. But again, I do encourage you to always follow your 5 steps when you're interpreting these rhythms. So our objectives. Understand the origin of atrial flutter in the cardiac conduction system. Describe the appearance of atrial flutter on the cardiac monitor. Calculate the atrial and ventricular rates of atrial flutter. Understand why the ventricular rhythm and atrial flutter may vary, and understand what occurs when an atrial wave is blocked from ventricular entry. So one of the things that's going to be a key diagnosis is that the atrial rate is going to be much higher than the ventricular rate, because the atria is going to have an ectopic focus that's caught into a re-entry pattern that eventually is released into the ventricles, but you're going to have a much higher ratio of P waves. And in this case, they're not regular P waves. They're going to be F waves or flutter waves that you'll see on the monitor. And so the flutter waves sometimes will be described as a sawtooth pattern as well. So F waves, like I mentioned, a re-entry circuit, a macro reentrant mechanism. The impulses originate at the top and move through an area of slower conduction, and they end up looping around and they end up conducting the tissue around them. And because of this, you'll have the flutter waves that are very easily recognized with atrial flutter. This is an example of that reentrant mechanism right here. So conduction ratio refers to the actual conduction rate through the AV node. The AV node acts as a gatekeeper to the ventricles. And normally the AV node senses atrial depolarization and holds the impulse for a few milliseconds to allow for ventricular filling. Then it allows the conduction to go into the ventricles. This results in a 1-to-1 ratio in a normal rhythm. But the conduction ratio for both the atria and the ventricles can vary in atrial flutter. So a 3-to-2 conduction means that 3 atrial complexes are conducted, but only 2 ventricular complexes are triggered. A block refers to a pathological interruption of the AV conduction. Atrial flutter can have a protective block and a pathologic block. A protective block prevents a dangerous tachycardia, and a pathologic block is secondary to an abnormal disease such as ischemic heart disease or some type of drug effect. A block and conduction ratio are not the same. A 3-to-2 block, for example, means that for every 3 P waves created, 2 are blocked and only 1 P wave is conducted. A 3-to-2 conduction ratio means that for every 3 P waves, 2 are conducted to the ventricles. So your atrial rate, this is an example of your ratios here. So you've got your flutter waves that are going through. The atrial rate is 300. And then in this example, you've got a 4-to-1 conduction. So you've got 4 flutter waves to 1 ventricular conduction. Now it's hidden, the first one's hidden here, but it's 1, 2, 3, 4 to 1. 1, 2, 3, 4 to 1. A 2-to-1 conduction is the same thing, except you've only got 2 flutter waves to 1 ventricular conduction. Ventricular complexes are typically narrow, but sometimes wide complexes can occur in some aberrancies. I listed that term earlier. If there's already a bundle branch block that the patient's experiencing, and also in some electrolyte abnormalities. Sometimes you can have a flutter with a variable conduction. You're not always going to have just a 3-to-1, 2-to-1 pattern. And this is usually due to some type of AV node issue. And in this case, it could cause an irregular rhythm. So again, the key here is that you're going to have to count your atrial rate and your ventricular rate. The atria is going to be regular. Sometimes the ventricles may be irregular. In most cases, if you've got a normal conduction ratio, or if you've got a conduction ratio, then the ventricles are going to be regular. Normal P waves are going to be absent. They're going to be replaced by your F waves or your flutter waves. You can't get a PR interval, so you can't measure that. And once the conduction makes it to the ventricles should depolarize normally, and your QRS should be less than 0.12 seconds. So here's a couple of more examples here. You've got a 4-to-1 conduction ratio here, and you've got a 3-to-1 conduction ratio here. So some things that can actually cause atrial flutter: myocardial infarction, atherosclerosis, digoxin, rheumatic heart disease, alcoholic holiday heart, thyrotoxicosis, pulmonary emboli, pericarditis, or pneumonia. So we're going to look at some examples that are not always just your textbook examples here. So this has flutter waves involved in it, but they're not as predominant. What you'll see is that you've got a variable conduction. So you've got a 3-to-1, 3-to-1, and then it widens out to where this one is 1, 2, 3, 4, 5, 6-to-1. But again, what we notice is the presence of flutter waves and variably conducted QRSs. So each blue dot recognizes a flutter wave, and then you've got your QRS here. This is a little bit harder to see here, but it is atrial flutter. Again, you've got flutter waves and a small QRS, flutter waves of different sizes here, and then a QRS. This is a variable conducted with recurring grouping, so you've got a 3-to-1, 3-to-1, 2-to-1, 3-to-1. So your clinical significance of atrial rhythms with atrial flutter is always going to be directly related to the patient's condition. If the ventricular rate is normal, although they may feel funny, it's usually well tolerated as far as hemodynamically goes. But whenever it triggers a fast ventricular rate, then you'll see a decrease in cardiac output. The treatment's going to be directed to decrease ventricular rate if it's really fast, either with medication or cardioversion. So in this case, we would follow the tachycardia algorithm.